Welcome to the Health Informatics Seminars. I'm David Potenziani. I am hosting today. Please remember, today's seminar is being recorded. Do mute your microphone while we are viewing the presentation. However, when we come to the Q&A segment, feel free to unmute yourself, pose questions, make comments for our presenter to discuss. Alternatively, you may post in the chat where I will relay your question or comment. So let's begin. Professor Kapoor, I believe you are introducing our speaker today.
Yes, thank you, Dave. Good afternoon, everyone. It is my pleasure to introduce our guest speaker for today. Dr. Sayali Tungare is an assistant professor in the Department of Clinical and Health Informatics at the McWilliams School of Biomedical Informatics, UT Health Houston. Trained as a dentist, public health professional, and health informatician, Dr. Tungare's research bridges clinical dentistry, data science, and public health to improve the quality and safety of oral healthcare. Her work focuses on leveraging electronic health records, patient-reported outcomes, and informatics-driven tools to advance evidence-based dental practice. She has led and contributed to federally funded projects from the National Institute of Dental and Craniofacial Research and the Agency for Healthcare Research and Quality, addressing topics such as opioid and antibiotic stewardship, dental adverse event detection, and the use of mobile health platforms to study post-operative pain. Her studies have demonstrated how data-driven feedback and human-centered design can enhance dental decision-making and patient engagement. Right, with that, over to you, Dr. Tungare.
Thank you very much, Dr. Kapoor, for that introduction. With that, I'll then move on to the next slide. Before that, I'll just say hello to everyone online and in person in North Carolina. I'm presenting from Houston, and today I'd love to share the research that we do here within dentistry and how we apply health informatics concepts and approaches within it. This is going to be a little non-traditional kind of a presentation where I'll mostly focus on our approach and touch a little bit, of course, on the results, the clinical findings, but because this is not a core clinical, non-dental kind of an audience, I would focus more on the key takeaways, what led to our study successes, what the limitations could have been, how we could improve that, and if you were to utilize this kind of an approach in your research, dental or not, what is it that you should maybe keep in mind, think about, prepare for, or you can maybe, from the next steps, think of an idea for your upcoming research. So with that said, I'll go on to our next slide. And we are going to first take a look at the learning objectives. By the end of this session, I hope that you'll be able to identify the various data sources and methods that we use and be able to describe the practical frameworks for implementing these informatics approaches in dental research. And to accomplish that, this is like a very high-level overview of the agenda. Mainly, first we'll look at repeatable pipeline that we typically use in our studies related to data processing. And then we are going to take a look at 3 different studies and the different data types that they use, different approaches that they used, and what our findings were from those 3 types of studies. So what our goal is over here is to deliver evidence-based, patient-centered oral healthcare. And in order to do that, the core concept that we follow is we bridge clinical care, data science, and public health and generate real-world evidence. This evidence then goes into informing that patient-centered oral healthcare. And the data for us lies at the center, at the heart of it. And these are the different kind of data sources that we work with. So we have data that comes from the electronic health records, dental records in our case. We have patient-reported outcomes related data. It could be collected via surveys administered through different survey platforms. It could be collected through mHealth platforms or applications. Then we have data that comes out of a dental data repository that we've built here at UT Health Houston. It's called Big Mouth Dental Data Repository, and I'll be talking a little bit about it towards the end. And you may be surprised to see this part where it says interviews as data sources for us, but all of our research, we use a triangulated approach of, combining quantitative, qualitative, and EHR data together for creating that evidence. And the interviews could be done for multiple purposes. It could be even like right from just understanding patient experiences, practitioner beliefs, to testing our mHealth platforms, our dashboards, involving the stakeholders in design and development of interventions. So there are multiple reasons why we do conduct interviews in all of our studies, and there is a lot of data that comes out of there as well, which is qualitative, rich data that informs the evidence. So as you all are aware, data comes in various forms and types, and these are just a few listed here. But mainly what we deal with is structured data, and it could be, anything from dental procedure codes, prescription level data. It could be numbers in the form of pain scores that patients report. It could be data that's related to socio-demographic factors, whatever it is, all of it comes under that structured data coming from these different sources. Unstructured data can come for us from, again, these different sources could range from anything between chart notes, all unstructured data, notes written out by dentists, after procedure, remote phone call visits, prescription instructions, data, unstructured qualitative data coming out of interviews, those kinds of things, patient and dentist interactions, those as well. And then we have radiographic and imaging data coming out from x-rays, from images of the oral cavity, lesions, and also data that is in the form of actual physical forms that are scanned into the systems, and we need to extract data from there. So using all of these different types of data, we have an iterative process of where we perform these 5 different functions, and we start off with data capture, of course. So data comes to us through one of these sources, or we extract it using queries, and then we put it into standardization. Now, standardization, you may feel like, why would that be needed when you are actually capturing the data yourself? A lot of times what we do see with our studies is data comes from different sources or different organizations, different sites, and they may or may not use the same EHR system, different patient-reported outcome instruments, and at that point is where we need to standardize the data. An example as simple as a gender variable in one organization's EHR system is coded as male, female, other. Second organization could have it as MFOU. A third would have a 0, 1, 2, 3, and we have to use a common data model to standardize all of that and put it together in one format. Then we move on to the analysis part, where we are able to actually either start off with descriptives or say deep statistical analysis. All of these either are used by themselves or go into the implementation of data. And what does implementation really entail? For us, it is mostly we implement data in the terms of providing it back at times to the practitioners, to the patients. We may provide it back as audit feedback dashboards. We may provide to them quality metrics, reports of their prescribing patterns, report of their patients, reported pain intensities, those kinds of things. It's data that's analyzed, put together in an understandable format, and implemented. These are also implemented at times as interventions, and all of these then go into evaluation of outcomes, and then they go back into the loop of capturing those and moving along forward with this iterative process. So that is typically the underlying model that we use across all of our studies. Now, next we'll look at the 3 different studies. And the first one that we are going to look at is using dental informatics in practice, private practice dentists. And in this study, we had used patient-reported outcomes. So for each of these studies, I'll first give you a quick overview of what it was about. Then we'll look at the approach and the findings, and then the key takeaways. So in this study, this was focused on understanding pain after dental procedures. And for y'all to know, dental procedures, especially the more invasive surgical ones, are associated with post-operative pain as well. So even after the procedure, the patients may have pain. And we wanted to study that. What are the factors associated with that pain? But we also wanted to facilitate communication between the practitioner and the patient throughout this follow-up period and see if that impacts the care that the patient receives in terms of pain management. This study was a US-wide study. We conducted it through the National Dental Practice-Based Research Network, which is like a group of dentists motivated to contribute to research through their practice. And we used an mHealth platform at the center of this, which I'll talk about in a little bit. So our goal was to understand through the study what the patient's post-operative pain experience is in terms of pain intensity, interference with their daily life, what's their satisfaction with the pain management strategies that the dentist has provided them with. And because mHealth platform was integral to this research, we also wanted to assess the usability and acceptance of the platform. So this is a very high-level overview of the study procedures that we had with mHealth platform being at the center of it. We had dental practitioners, providers, dentists, basically, who we recruited into the study through the National Dental PBRN. And they, in turn, recruited their patients who were eligible for participating in the study, meaning patients who would have undergone those select invasive surgical dental procedures. Once the patient had undergone the procedure, recruited into the study, the practitioner registered them into the platform, mHealth platform, and the patient received survey links through text messages on their phone. So there was no app to be downloaded anywhere as such. The links to the mHealth surveys were directly received as text messages on their phones, and they could respond to them by clicking on the link, and those responses would go back to the practitioner to tell them about how much pain the patient may be feeling, what their experiences are, if they have any complications, those kinds of things. And this was done over a period of 21 days after the procedure, day 0 being the day of the procedure. And on the left here, if you see, is a video of how a patient would receive that message. They click on the link, they're taken to the survey, and they answer questions about their pain experience, if they have any other discomfort, the medications that they take, if they have any complications like swelling, bleeding, and then the interference with their daily life in terms of eating, speaking, ability to fall asleep, those kinds of things. We also asked how satisfied they were with the pain management. And at the end, they were able to ask the dentist a question if they had one. So they could send a message to the dentist, something like, oh, you know, this area is swollen, what do I do? The medication that you had prescribed, I couldn't find it, anything of the sort, whatever they wanted to ask the dentist about or let them know about, they could send that message. It would go into the system, alert the dentist or notify them, and then the dentist could respond to it through the platform. The patient would again receive it and they could have a conversation about it. So this is how the platform worked, and the data collected through this was what we used in the study for analysis. And what did we collect? Data on these exposure level variables, other covariates related to demographic, socioeconomic patient factors, clinical and demographic practitioner factors, different procedure-related information, medications that were taken, prescribed, complications that were experienced, those things. And then in terms of outcomes, we had 4 different outcomes that we were interested in. So first one was pain intensity, and it was collected across the 21 days. It was measured on a scale of 0 to 10, 0 being no pain, 10 being the highest. Same for pain interference. We had 5 measures collected day 7 through 21, and again scored on a scale of 0 to 10. Satisfaction and participation collected on day 7, and at the end of their participation, they filled out either the SUS, the System Usability Scale survey, or the UTOT for technology usability and acceptance. Overall, in terms of enrollment, our goal was 3,147 patients to be recruited, of which we were able to recruit 3,139 by 144 dentists. So we were pretty close. Our study was powered for a response rate of 60%, but we passed that by a lot. And we had good response rates of 75 to 80%, depending on which day of survey it was. So they did respond to a lot of the structured quantitative questions. And then there were 563 doctor-patient interactions in terms of the messaging service being used as well. Oh, and this is the distribution of the patients across the United States geographically. So what did we find out? Pain post-operatively, even after these invasive dental procedures, isn't too bad on an average. There was pain about 1.7 to 2.7 out of a 10, which is a mild level of pain, depending on which procedure you get. That's why this range. So not too bad. What we were able to find out that those patients who did report higher, more severe pain, it was mostly seen in younger patients who were females, who had severe preoperative pain, and then who had undergone these specific dental procedures, or if you had multiple dental procedures on the same day. Similarly, for pain interference, we actually saw that there was very mild to no interference in terms of performing daily activities, falling asleep or staying asleep. The most interference that patients reported was with eating food and speaking after undergoing these specific procedures, though not for all of them. We also engaged the dentists to understand the pain intensity that they predict for their patients. So the patient responds to the same question, and the dentist also responds to the same question and predicts what could be the pain that the patient is going to experience. And we wanted to assess this to see whether dentists are accurate in predicting that, because their pain management strategies are basically derived from that prediction, right? So we did find out that about 80% of the times dentists overestimated pain that the patients will experience, and the patients in reality did not actually experience as much pain. And we similarly found that dentists, on the other hand, actually did not prescribe as much of the prescription medications, so be them opioids or antibiotics, but patients reported taking those medications to a lot more extent. So these are areas that we are still studying. This analysis is ongoing, so we'll have more to share later, but we are looking into this, and this is what we have found out so far. And lastly, in terms of usability of the platform, the patients scored it on an average altogether after the system usability scale score analysis, 90 out of 100, which is excellent if you know how the scale is scored. So it was a very good score. And based on the UTOT that the practitioners filled out, they perceive this platform as useful, easy to use, and it would likely improve their performance in terms of patient follow-up. So all of this being said, the study went well, good findings. What is the actual thing that we learned from it? Takeaways for you all, what made this study successful is what I would like to share is these were the critical components. The practitioners were highly motivated and interested in participating in research. The patients were interested too, but they were also interested in this mHealth technology and having that direct access to the dentist themselves. Because if you know, and if you have gone to a healthcare provider, there is only that limited time that you get to interact with your actual doctor, and everything else before or after is interaction with someone else. And this opportunity to be able to communicate with them, reach out to them, was something that did motivate the patients. You have to also remember, I mentioned that the practitioners recruited the patients. So the practitioner-patient relationship also was a factor that played a role in the recruitment. Because think about a third person, a research person consenting a patient in a clinic and saying, oh, we are conducting this research, will you participate, versus your own doctor, dentist coming to you and saying, oh, hey, I'm participating in this research and you qualify, would you like to? And that does make a difference. So I think that was also crucial. And another thing that was very critical to the study was we had personnel dedicated for the monitoring of recruitment and to provide support related to the mHealth platform. So if there was anything needed, a dentist reaching out to us that, oh, this is not getting sent, I'm not able to receive something, I registered, but I can't see the patient, there was a team to troubleshoot those kinds of things. So that was helpful. I would say this study, while it was ongoing in terms of data collection, did take a lot of time and effort in terms of training and monitoring. So we trained dentists to participate, and the training material that was developed, the trainings that were actually provided to the dentists, that was a big part of the study, as well as the daily monitoring in terms of whether the surveys are being sent out through the platform. All of the process was automated, but for someone to even oversee that, it's happening across thousands of patients. We spent quite a bit of effort in that. And out of all of this, for us, yes, the numbers are great, the findings are good. What was really key in terms of what we understood was the real-time information that was provided to the practitioners was critical to them, and they really appreciated it and felt more engaged in caring for their patients. They also thought that it reduced the staff burden that was there in terms of following up, the time, the effort that their staff spent. They did see that the patients felt a better sense of care as well, and they were more grateful. They were happier. They did use the messaging service to say a lot of thank yous too. When we analyzed that, we did see it, and then it was also helpful in terms of providing that clinical decision support where they were actually able to see, oh, this patient is not in as much pain, and I've prescribed something, he may not need to take it anymore. And to modify that pain management strategy, this real-time information was really helpful. After all of this, we did interview practitioners about a lot of different things, but also to understand if they were to use this in the future or if there were any improvements to be done, what is it that they recommend? And the main thing that we heard, which was common across multiple interviews, was the integration of this mHealth platform with their EHR systems, patient management and scheduling systems, so that they don't have to go to these different places to be able to see something. They just want one place they log into and are able to see the complete information. So that is what we learned. And then I will go over the next two studies as well, and I think we'll keep all the questions towards the end. So the next study is about informatics and learning health systems. And in this study particularly, we had electronic health record-based data. So we used informatics and data-driven approaches for antibiotic stewardship in dentistry. In here, this study was across two large dental care systems. So they have multiple dental clinics. Geographically, we are talking about Pacific Northwest and Midwest regions of the United States, and across 70 total dental clinics. And our goal was to be able to quantify evidence discordant antibiotic prescribing. So there are antibiotics being prescribed by dentists. We wanted to quantify, are these really necessary based on the evidence that's out there as to when to prescribe an antibiotic in a dental situation versus not. And then we further want to iteratively develop improvement strategies to reduce this. So we are following this learning health system framework. Many of you may be aware of this, where the data flows from practice to data, data to knowledge, knowledge to practice, and the loop goes on. Right now, we have accomplished steps 1 through 4, and I'll be talking about those in the next slide. And this is an ongoing research project. So our goal here was to develop and validate an EHR-based algorithm. We have this data from EHR. We want an algorithm that would be able to determine whether, based on the evidence that's out there, is this prescription concordant with that or not? Is it guideline concordant, evidence concordant or not? And our activities spanned across these different sections. So first, we started off with collecting practice-based data from these EHR systems. At the same time, we also started review of the literature to see what the current guidelines are, what the current evidence is in terms of when should an antibiotic be prescribed in dentistry. Then we assembled this data from the EHR using common data models. Remember, they use two different EHR systems. So some may have certain variables, some may not. So We figured that out first, standardized the data, and captured it. At the same time, the review of the literature yielded a decision tree that can be used to determine whether this antibiotic is indicated by evidence or not. And then we did these two processes simultaneously. So we had started developing computer-based algorithms that used the structured data from here as well as unstructured data, a lot of unstructured data actually, spanning across multiple visits, multiple nodes, that was processed using natural language processing. And all of this together was then, along with the decision tree, was able to provide us with an output that classified a prescription as whether it is evidence concordant or evidence discordant. And after, while that was being done, we also had two chart reviewers at each of the sites evaluating the same set of prescriptions using the same decision tree and saying whether that prescription is concordant with evidence or not. And then we compared the algorithmic outputs to the gold standard chart review conducted by clinicians. And these, while we were doing it, we were aware that it should also be done iteratively. It's not something that we do once and done. We realized the model performance kept on improving as we were able to feed it with more information. And we did that until we felt that the model is now pretty close to how a reviewer or an actual human would classify this. And last month is when we actually were able to see the results. And first, we did see that a lot of antibiotic prescribing in dentistry was not really needed. But apart from that, we were also able to see that the algorithm was highly accurate in detecting this. And we had an accuracy of about 98%. And precision at 98% as well, with a kappa above 80. So the algorithm did perform well, and we are now implementing it on more current data sets for the next steps in our study. So in this particular research, and this was just the first aim, it's an ongoing study. We are 2 years down, 3 more years to go. What we have learned so far is that it was a highly iterative process of continuous development, testing, validation that spanned over 1.5 years. Also, it was a highly collaborative research. So we had experts from these different fields, right from clinical dentistry, pharmacy, informatics, public health, stats, every background pertaining to this particular research, working together. We divided the team into different work groups that could work simultaneously. And one could focus on developing that decision tree. It was mainly clinicians, pharmacy experts, infectious disease prevention experts working on evaluating the evidence to develop that decision tree. We had informaticians, statisticians, public health experts working on the algorithm development, and then again, clinicians working on the chart reviews. So it was a highly collaborative effort from experts from different fields. Through this, we were able to contribute to the science and make very novel contributions at that. This is one of the first evidence-based antibiotic prescribing decision trees in dentistry. And this can be used as a clinical decision support tool, be it Chairside to be used by dentists, or be it using manual chart reviews in clinics. Or if you want to develop an algorithm, you could take this and your data, and you could do that as well. So that's what we were able to develop. And in terms of next steps, we are interested in understanding what are the factors associated with the high amount of discordant antibiotic prescribing. And then we'll progress to developing interventions to reduce the unnecessary antibiotic prescribing, and hopefully empower dentists to follow evidence-based prescribing. Next, I'll talk about this study that utilized audit and feedback as intervention and used data from electronic health records as well as patient-reported outcomes. So this study was focused on reducing opioid prescribing in dentistry through audit and feedback. This was a small-scale, formative study done at one dental institution over a period of 2 years. It was a clinical trial to test whether providing audit and feedback of prescribing practices and patient-reported outcomes of their post-operative dental pain intensities, does that influence the dentist's prescribing behavior? So we had this kind of implementation framework that we used. We used routinely collected clinical data, had performance measures, benchmarks from their past performance, peer performance, the typical things that go into an audit and feedback mechanism. And we evaluated all this information along with the current guidelines and recommendations to provide targeted clinical goals or performance goals. And the goals, along with their own clinical performance, once it was provided to the recipient, we let them assess it, see if it changes their intention in terms of improving clinical performance. We also supplemented it with patient-reported outcomes at that stage and tried to see if it promotes any behavior change and any change in clinical performance at all. So our hypothesis was that when dentists are provided with audit and feedback of their prescribing patterns, this was done through using data from their electronic dental records. And when they are provided patient-reported outcomes in terms of their pain levels and experiences collected through post-operative surveys, does that aid the dentist's clinical decision-making, and whether that reduces the opioid prescribing caused due to these different reasons. And these were the dashboards that we used in the study. So the dashboards focused on their own prescribing patterns across a 2-year period. And they had the 3-month rate, 24-month rate, whether their rates met the specialty's goal. So specialty meaning the dental specialist that they are and that clinic's goal. The number of opioids that they have prescribed, the number of total visits that they've had. And then there were other tabs that they could navigate to look at patient-reported outcomes, look at detailed information in terms of procedures. So this is what we had. We had comparison groups in terms of the specialty's overall rate. And on this next dashboard, which was under procedure details, they are able to see by each procedure type that they have done, what their prescribing rate was, what the average is for their specialty. And down here, if you see this is the patient-reported outcome data, which we were able to provide and show that if a patient took an opioid, which is the orange circle, and had this procedure, what was their average pain score versus patients that did not take an opioid, the gray circles, what was their average pain score for that same procedure type. And dentists were thus able to compare that out of the patients that have undergone these different procedure types, whether providing an opioid or not makes a difference, whether taking an opioid or not makes a difference in their post-operative pain levels. and then decide for themselves whether it's necessary to prescribe. We also had on the top what the current guideline is for opioid prescribing in dentistry, as a reminder. And for there was a link to the institutional guidelines as well on prescribing if they needed resources. This is what we followed in terms of study design and what the findings were. So because this was a clinical randomized controlled clinical trial, we stratified the groups by their dental specialty. So a general dentist versus oral surgeon versus endodontist versus periodontist, which are different dental specialties. We used those to stratify which group they are assigned to randomly. We had 20% in control and 40 and 40% distributed as standard dashboard, wherein they just got the audit and feedback of their own prescribing practice, their peers, but the enhanced version to the rest of the 40% who also got the patient-reported outcomes of their pain intensity and which medication they had taken. And what we found out was that those groups that were provided the dashboards, be it standard or enhanced, did have lower odds of prescribing an opioid as compared to dentists who did not receive any dashboards at all. So the dashboards were effective in reducing the prescribing behavior. Through this study, mainly we learned that including or incorporating audit and feedback elements meant that you needed to ensure the quality of your data and its accuracy all the time. And at least in the beginning, we spent a lot of time to make sure that the data is accurate, the way we are presenting it on the dashboards, the rates that we are calculating are accurate, to make sure that this, what is the truth, is actually being displayed, and there is no difference in what's going on versus how we are calculating something. So that did take us quite a bit, which takes us to the next point about prescribing rate calculations. Where we had implemented the study, we did not have visit level or encounter level data. Data was either by procedure done or prescription made, and we had to actually create the visit level data for denominator counts by looking at a procedure and checking for a prescription plus or minus 7 days or the other way around. And we decided on those things and created visit level data for the denominator counts. Then we also had these Tableau dashboards set up to be updated real time, which meant we had to have a robust pipeline for data capture, it being fed to the dashboards, ensuring those the connection to those tables and setting up automations for that. So that was crucial step in this dashboard creation. And then lastly, we also saw that if we were to utilize these and clinicians in their busy routines were to actually go see this, they would need to be reminded. And we set up a reminder via email every month with the link to their dashboards, and that kind of, helped in them going back to it, engaging with it. So that was critical for us. In terms of developing these and designing these, we engaged the stakeholders, dentists, right from the beginning, and involved them in the design, in the usability testing, throughout the process in the first year until we had developed these and then implemented them for the next year. So that was also vital to the success of creating highly usable dashboards. And lastly, because this was a clinical trial design, needed stratified randomization. If you are working with clinical research, prescribing related research, especially in dentistry, there are certain procedures, or dental specialties that would need or would prescribe these medications more than the others just because of the procedures that are being done. So a surgeon who's taking out 4 teeth surgically, manipulating the bone, the oral mucosa, versus someone who's doing a filling are two different kinds of participants. And we wanted to ensure an equal distribution of those and start off with equal baseline re-intervention prescribing rates. So that was also something that took us a little bit of time thinking as to how would it be appropriate to stratify them. And for this study, the next step is for us to perform a large-scale implementation to study whether there is a difference between the group that gets an audit and feedback dashboard only versus audit and feedback dashboard with the patient-reported outcomes, and see if there is a difference between those groups as such. With that, I am at the end of presenting my research studies, and I would like to thank the funding agencies that support this research, the partnerships that we have with these different organizations where we conduct the research, our UT Health Houston research and clinical teams, as well as the patients and dentists who participate in the research. And lastly, thanks to you all for your interest and for listening to this. I do have 3 or 4 more slides to talk about the Big Mouth Dental Data Repository. And this is just to share a resource with you all. And I want to end it with this because this is something, if you are interested in collaborating or starting off in the field of dental research and do not know where to find the data or cannot really collect firsthand data, this is a great resource. So I'd like to highlight this. This is the Big Mouth Dental Data Repository. Data is contributed from across the US through these different organizations. This is how it compares to the different big data resources. These have very less oral health related data. Big Mouth has over 7 million patients in the database, mainly supports clinical research. It's partly publicly accessible as well, and the data mostly comes out of the EHR. It's the biggest clinical data repository in dentistry in the US. It has supported many queries. Dozens of studies have been published, and it does foster a lot of collaborations within institutions and internationally. So if you're interested, this is the QR code. You can take a look at it. Once you go to the site, even if you type it out, there are many publicly accessible dashboards that will show you the kind of data that there is, which you may want to use for your research. So with that, I'll stop. Thank you again, and I'll take any questions.
Well, thank you very much. This was quite interesting. We have one question in the chat. I've got a few. I'm looking at my students to see if they have any. The question in the chat, let me rearrange it a little bit. First, thank you for reporting with your strong data collection study, your first study. And this person was asking, I think communications helps patients feel connected. When you say in study 1, patients felt happier, was this a personal comparison to no communications or to earlier procedures? Can you share a quote from a patient?
Great. Yes, to share a quote, I can definitely go back to the qualitative interview data that we have and share that. But I can definitely say this, that we do not have any comparison data as such. But when we are saying happier or that they felt a sense of better care, this was also expressed to the dentists by the patients. And these are seen through the chat messages that are sent to the dentist, as well as in the dentist interviews when the dentists were talking about impact on their clinical practice, and how they felt this changed their practice or their relationship with the patients. Was it too much to do? Were the patients frustrated about the frequency of the surveys? Those kinds of things. That's when the dentists talked about it, and they said the patients were most of the times grateful, and that when they did have to schedule an actual follow-up visit and the patients came, they seemed happier to have that opportunity to be in touch with the dentist than not having that previously.
Thank you.
Mhm.
In that study, were there any challenges of patient access to mobile devices, not just physical access, but also privacy of their data when perhaps they may be using a shared device?
Oh yeah, of course. So two things. First one of our inclusion criteria were for the patients to have the ability to have a cell phone with internet access, to be able to click on the link, survey link, and fill out those surveys housed on the mHealth platform. Secondly, we did have patients who did not consent to be a part of the study. So we had weekly logs of patients that the dentists did approach and recruit, but the patients did ask either questions about is the data safe? How is it going to be shared? Are only you going to access it? Because this is also being used for research. Is it going to be de-identified? Those kinds of things. I would say there were not many patients who were concerned about that, but we did hear about this from a few dentists. Apart from that, that we did not hear about any withdrawals or anything as such, which was due to data security or privacy related concerns.
Okay, thank you. We have a question in the room.
Okay.
Hold on.
Mhm.
Hi, thank you so much. Excellent analysis. And I really appreciated how focused on applicability, all these data analytics were, both for the patient experience as well as the providers. I'm not sure which study this sort of relates to, but you had mentioned higher rates of pain among young females.
Mhm.
And I was curious kind of how that was captured by or it resulted from, if it was in the opioid study. I'm just thinking as from clinician research, oftentimes females' pain is kind of pushed to the side. I'm just kind of curious if any of the practices of, being impacted to be less likely to prescribe opioids might be putting young females at a disadvantage, or like where the data analytics were analyzed or implemented around that question, if it was even part of that study.
Yes. So I can tell you this. I was myself involved with the data analysis of the data we collected in this study. So I can talk a little bit about the methods that we used. So over here, if I can remind you, this is across all patients that we had, and they had the same scale of rating their pain experience. And when we did this analysis, we used adjusted logistic regression models to basically adjust for different socio-demographic and economic factors associated with the patients, as well as clinical factors. All of them went into the model, and we had conducted a univariate analysis for variable selection first, then proceeded with the final analysis. And from all of that, even in the univariate versus the adjusted models, we always saw that the patients, after adjusting for all the variables, female patients had statistically higher odds of experiencing post-operative dental pain between days 1 through 7 post-operatively as compared to male patients.
Thank you. Deborah Swain, I believe you have your hand up.
Yes, I just wanted to comment that I'm very interested in knowledge management and look forward to your 5-year plan. You're into like year 3, I think, and getting data flow into practice is just not easy, but you've got the right model. Thank you very much.
Thank you. Thank you very much. I appreciate that.
Well, let me follow up on that question. A dashboard seems to suggest monitoring by outsiders. Did you ask any questions or probe the thinking of those dentists whose prescribing practices changed when they started using dashboards, try to see what was underneath the surface?
Right. So unfortunately, we did not conduct those interviews at the end of the study. After this was implemented, that behavior change had happened. But our goal is to implement that in this larger antibiotic stewardship study. So we are going to see through a co-design kind of mechanism of what interventions we come up with, but there would be a dashboard part to the multiple interventions that we may have. And there is, we are already conducting those interviews with patients. We have completed them at one site, and I can say that patient education awareness is going to be one aspect of the interventions that we develop. But in terms of practitioners, it's going to be more about providing them these audit and feedback dashboards as one of the interventions. And that is definitely when we would want to understand, once we have implemented and once we see that behavior change, if we see that behavior change or not, what was it that drove them to the change?
Well, so let me turn this sideways and around.
Mm-hmm.
Of course, we are now all sensitized to the misuse of opioids because of the experience of the past 30 years. And I'm wondering, you are looking at this focusing on patients and clinicians, but I'm wondering if there are training or policy implications of your findings that you are thinking about sharing with those who do determine what kinds of training are needed or what kinds of policy are needed.
Yes, and that would come eventually. So right now, at least in terms of opioid prescribing, we are in the formative stages of the understanding part of the problem, as well as developing interventions to drive any kind of stewardship around it. And even from the side of policy, we need, I think, a large scale study that would be able to show that and inform policy as such. So yes, eventually, as of now, we have not engaged with any policymakers as such.
Okay. Well, we are just about out of time. Thank you very much. This was a splendid presentation. You are clearly very busy. And so we thank everyone for attending today and look forward to seeing you again next week.
Thank you very much. And if there are any questions you'd like to ask, you can also email me. That's all that I want to request. Thank you very much for this opportunity.